So just so you all are aware, again, if you want to get your stakeholders to a call to talk about coding for food or the open program classification, this is the meeting to come to every other week, 4 o'clock to 5:30 Eastern Standard Time. Feel free to disseminate and reach out to us for more information. Next slide. Thanks for joining the call. So everyone's muted upon entry. This is a very communal call, right? We are a community of practice. We, value each other's opinions. This is not incredibly formal. Our process is formal. Our conversations are not, right? So we follow a very formal cycle and process, but please feel free to raise your hand and talk to the community or ask questions as we go along. All calls are recorded. Recordings are available on the Gravity Confluence after the call. Participate, send comments to chats. And again, we're just starting to broach some of the coding for food concepts, high level touching base today, and 2 weeks to come back with a little more nitty gritty concepts for you all to chew over. But really excited to be able to bring this work finally to the public meeting. It's been many years in the process. Katie can attest. Next slide. This is the common antitrust practices statement as a open standards initiative. Yeah, Lucy. We are required to follow antitrust practices requirements. So all participants in all public calls have the responsibility to comply fully with federal and state antitrust laws. This is just part of the nature of our standards development work. We try to be generous in our application of those standards, so it includes not just avoidance of antitrust violations, but also avoidance of behavior that might be so construed. The nature of our calls doesn't tend to verge in these topics, but it's important as a standard development entity to ground ourselves in these principles and practices. Next slide. All right, so the welcome. I'm trying to cover that. I have a few other things. Sarah DeSilvi, Director of Terminology for Gravity Project. Coding for Food re-kickoff. Katie, I hope you like my parentheses there. We did a kickoff last year, I think. Initially just presenting the idea and really excited to get into some of the process and content and questions more deeply. And then we'll be offering up some program classification updates as well. So again, for those of you trying to invite your friends to the call, this will be the structure every time as we go forward, centering coding for food first, right? So if you want to bring your community members and stakeholders to the call, starting usually from the 4 o'clock Eastern Standard Time and right after time frame through the first half of the meeting. And then we're going to center into program classification next. This is so that you don't have your entities who are precious with time coming to meetings where we're not maybe talking about things that apply to you. I do want to note we have many entities where both of these concepts are really pressing and important to them. So a lot of folks will be on the call for the whole time. And then we will close with community homework and next steps. Next slide. Okay, next slide. So this is just, again, our general announcements page. So for terminology work stream, which is this work stream, we did present on the utility and security IC10CM concepts at the IC10 Coordination and Maintenance Committee. Again, our job, we are terminology and language makers. So this includes developing most of the new Z codes within IC10CM. We presented on that in collaboration with our friends at the National Center for Healthcare Statistics, Vital Healthcare Statistics at CDC on September 10th. And then there is a period of public comment available until November 15th. Any comments in support of our concepts can be sent to the email there. Technical work stream, the sister work stream for terminology. We did publish just recently the STU 2.2 and are working through ID revisions. The meetings where that happens are Wednesdays Eastern Standard Time from 1 to 2. An implementation, I just came off a call. This is Sarah DeSilvi talking for 3 hours today. We just had an implementation affinity meeting just today. It is the last Thursday of every month. Our next meeting is October 31st, exciting day. Of note, this meeting we just had might be of interest to some of you. The topic was implementation tips and tricks. So how do you not boil the ocean when you're looking at all the possible gravity terminologies, but implement based on the drivers for your particular ecosystem. So that will be recorded and available on the Confluence very shortly. Next slide. All right, any questions on announcements? Because we have a lot of fun things to discuss. All right, next slide, we're gonna get into it. I see lots of our Coding for Food friends. I see some friends involved in exchange. I'm just trying to see if I see any of our, I don't see any of our classification SMEs today, but we just had a really wonderful meeting this morning, so I'll try my best as I can to represent them. So what is Gravity Project? We are a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. We just try to center on this every time. Very, very grateful for our members and sponsors. The cool thing about Coding for Food is I get to connect again with some of my favorite folk, grassroots community-based organizations delivering food to people. In light of that, I want to note that Gravity is like the HL7 of accelerator of reference that has this entity called the designated members, right? That if you're, oh, there's Elena, our classification subject matter expert on the call. Hi, Elena Kalinowski. My dear friend. She's also a good example of a designated member who is not a member by sponsorship, but a member by design, right? Because we cannot do this work from a social justice framework without including the voices that directly provide care and patients that are affected by it. And so our designated members center community-based organization voices and patient voices in that work, which is pretty important. Again, very common community organizing. I was a community organizer long before I was this, so just trying to work on that who needs to be at the table perspective. Next slide. We couldn't do any of this without our members, so very grateful. Super excited to have Coding for Food no longer a dotted line on the roadmap. Hooray, hooray. So this is our Gravity 2024 roadmap. Look very shortly. So we just finalized our 2025 roadmap. Our next terminology meeting next week will show that, the new domains for 2025. We are solidly in our 2024 cycle though right now, which includes the new domains of language barriers and incarceration status, that alternating meeting, and then working on enhancements in this meeting, so Coding for Food and program classification. All the while, we are continuing to iterate on some of our new use cases, not just screening and assessment using standard instruments, diagnoses, goal setting, and interventions, but how do we support outcomes measurement? How do we support payment and reporting? So we're always trying to evolve to make sure we're meeting implementer and member needs, and more to come on that. Working on our new version of STU clinical care, new version of the implementation guide, aligning with US Core 6.1. I'm sorry, I've been talking a long time, so I'm I need to drink more tea. And then all the while working on our implementation affinity group. We just had our meeting just a few minutes ago. We also are really trying to lean into supporting materials for education dissemination, creating artifacts. We don't just create terms in our Gravity meetings, and those of you who are regularly attend Gravity terminology meetings know this. We're also like a summit of sorts on hot topics in medical and social care integration. So we are trying to elevate these findings and deliverables and artifacts regarding some of the knowledge and opinions and collective statements that we make as well. More to come on those in the last half of 2024. Concepts on using structure maps, concepts on IC10-CM application, just things that are, decisions we come to collectively that aren't necessarily a value set with a data stamp on it. Each of the domains we're working in right now, incarceration status, language barriers, and Coding for Food, have significant policy statements aligned with them. So we were talking about this in all of our work groups. As we write concepts for Coding for Food, we also are going to be working to represent the expertise of that subject matter expert gathering on desired best practices and policy as well. So that's part of what we see as the work we're doing together. Again, artifacts and not just data. Next slide. All right, so I just reiterated this. So atypical, but perhaps a pattern going forward. We have alternating cycles with 2 different areas of work for fall 2024. New domain terminology development, that normal Gravity terminology curation process, and enhancements. So you can see that's the Coding for Food and classification. That's this meeting. It involves weekly meetings where we used to only have every other week meetings. Next slide. You can see that we have the regular new domain work happening last week and next week, all heading to that November 21st consensus vote. And then next slide. We have this meeting, which is focusing on program classification and coding for food, right? So every single week meeting, alternating topics, subject matter experts meeting in between. We'll go more into that as we go forward. Next slide. Again, November 21st is hopefully the vote, because we, as you'll learn as we get into coding for food, we are aiming for a MERIS submission on time for the 2025 cycle. That's our goal. Any questions on the calendar and updates? None of that should be new to those of you who've been in the call before, and we mostly have guests of subject matter experts who got all of that as part of the orientation in the Coding for Food work group. I think we're pretty good. Okay, next slide. All right, this is the terminology identification section, the topic of the call. Next slide. Everything that we are doing and all the artifacts we create in terminology are available in the Confluence. So you can find Coding for Food as an outgrowth of the food insecurity work. There'll be a caveat asterisk on that in a couple slides. And then you can find the language barriers and incarceration status in the domain work as well. The classification work is in a different section. It's in an area that we call cross-domain build, because it's not just one domain. So all of this is available on the Confluence. This is the key. Coding for Food does not have artifacts right now to download like a master version of sorts yet, but there's lots of materials to review. Have fun and look and see and read background information if you wish. The other entities, language barriers, incarceration status, and program classification do have current masters for review if you wish to engage in that work at this time. Next slide. All right, Coding for Food. Yay! You'll see this in the next slides, but I'm super honored to, Gravity is super honored to partner with National Food as Medicine leaders in the ecosystem on this work. Longtime friends because of our previous work on food insecurity. Helping to spearhead that is the amazing Katie Ettman. Just going to wave her hand. Who is a leader in this space, and so she helps. You're going to read about that partnership as we go forward in the next slides. Also on the call are many of our subject matter experts. More to come on that. Next slide. So we did present a kickoff on Coding for Food a year ago. There is a kind of why statement there and some introductory materials on the Confluence. Look for more to come very, very shortly, right? So our colleague, Sarah Bahal, that you know very, very well, will be working with us to ensure that some of that information is up to date now that we can formally kick off the process. The what are we working on specifically in this cycle, or the aim is to submit HCPCS Level 2 requests for 3 specific concepts. More to come on all of what that means over the next slide. Those 3 concepts are medically tailored meals, medically tailored groceries, and produce prescription. Again, the background on the Confluence, the why goes into this in great detail, but any of us, Katie, or any of the subject matter experts on the call can detail how heavily and extensively these kinds of programs are implemented in Medicaid partnerships, whether it be waivers or in lieu of services, even non-Medicaid payer programs supporting these entities because of the evidentiary base and how they align with healthcare outcomes. It is definitely something that is required in the ecosystem. So very, very excited to kick off this work formally. There's a lot of resources on Confluence for review. Katie, do you want to add anything to that? Are you feeling like that's okay? We're good. Okay, just pipe in if you wish. And then this is a really important thing to note, and this is the caveat asterisk that I mentioned. Coding for Food concepts are by in no means bound to the concept of food insecurity, right? So you do not have to be food insecure to leverage medically tailored meals, medically tailored groceries, or produce prescriptions. These are programs we identified as being important in our work for food insecurity, and this work is issuing out of food insecurity. So all of that work on these concepts is in that parent. But I just wanted to state it very clearly because we prescribe produce prescriptions for heart failure, for diabetes, for a host of different entities, extensive research on medically tailored meals and discharge and readmissions rates. I mean, these are very healthcare oriented concepts that do not require food insecurity to be the medical necessity driver. We're talking more about that in our work groups, but just note we're saying that out from the front, right? So we're building it within food insecurity. It is not bound only to food insecurity, and we're just going to say that from the outset so everyone's on the same page. Next slide. Okay. So this is a big slide, a lot of words. My apologies. I had a lot of slides to make today. So this is the structure, and this is like something we haven't been able to bring to you for until now. So we're very, very grateful to finally be able to bring it to you all and talk about what we've been doing. So as I mentioned, the Coding for Food work is a partnership with Gravity and leading food medicine leaders across the ecosystem, spearheaded by our longtime colleague, Katie Etman of Fulwell and Kristen Sukas, who it's very, very sad. Kristen's going to be moving on to greener pastures or more stable pastures, public health pastures very shortly, but we wouldn't have been able to do this work without her. Personally, as someone who was the former food insecurity subject matter expert, I've known Katie and Kristen for like a decade. I don't even know how long. It's a long time. So I'm very grateful to work with them again. And you'll see in the next slides how extensive the advisory group and subject matter expertise is on this work. Because it is HCPCS and because it is a food concept, we are really excited. Gravity team is being joined and augmented by our friend Tim McNeil of Freedman's Health, who is also part of the partnership to align social care. You know, Gravity is an integrator. We try to ensure that we are collaborating on things and we are that consensus space, and Tim's expertise is perfect for this. So thank you, Tim, for joining us. We're very grateful to have you as part of the team.
And I will throw in one thing here, Sarah, on that, which is we are so lucky that we are focused on HCPCS, which are like the service, the thing, and Partnership to Align Social Care has done so much work in the labor of making sure that these things happen. And so being in partnership, we know is really key to this actually working in the real world.
Yes. And the partnership are also really amazing friends in implementation, right? And so the great thing about our collaboration with entities like the Partnership to Align Social Care is we really, like, many hands make labor light, right? So I'm very, very grateful. And well said, Katie. There for Coding for Food does have an overarching advisory committee. Oh, and the partnership has leaders within our government. So Gravity builds in partnership into our leadership structure as well. Like June Simmons from the partnership is part of our steering committee. We're very intentional about trying to make that space and that collaboration happen by design, just as we are with our designated members, right? Like, who do we need at the table? Who's going to help us get this right? Come join, right? So there is an overarching advisory committee. This is a bit unique for Gravity that has been guiding the path toward the project deliverables. We'll talk more about that going forward. Each concept in this cycle, those 3 concepts, has a work group comprised of experts in the provision of the service. And you can see these experts on the call, right? So that is very normal for Gravity. So these are the subject matter experts of the domain of reference or the concept of reference. Just like with Gravity, those subject matter experts were selected by application and revision, right? So you review CVs and applications, ensure you have a good representation. I want to applaud Katie and Kristen and the advisory committee for ensuring representation across different regions of the country, different rurality and urbanity considerations, like really trying to make sure that the work groups were able to represent the breadth of what is happening in each of those different concepts across the country. That is helping us forge a common national standard, right? Because you can't create a standard for one program with one population. A HCPCS code has to be national, right? So all of that happened in the application process with a thoughtful inclusion of, again, all of those variables. The 3 work groups meet every other week on the path toward that consensus vote. Okay, I think, no, these are, Molly, I'm not missing anything. Molly is diligently dropping things in the chat. Hamali is doing 2 jobs today, right? Because our wonderful Sarah Bahal is taking a holiday, well-deserved, Sarah. And so thanks, Hamali, for doing everything. Just like with anything else, we're going to be using this space to talk in consensus in public regarding these concepts. So if you have entities that you want to be part of this call, this is the cycle, right? Every other week starting now, as I mentioned. And then the goal is to submit our consensus concepts to MIRIS, which is the HCPCS submission portal, in December, in time for the January deadline, right? That's the plan, right? We're going to go more into the what over the next slides. Next slide. You can see this is a lot of work in the background. If it took a year, it's clear why. is a lot. So this is the amazing Coding for Food Advisory Committee. So those of you who have not had the pleasure of seeing this before, it is very impressive, right? It includes friends from the Academy of Nutrition and Dietetics, our friends at the Harvard Center for Health Law and Policy, friends from CMI, friends from like leaders in food as medicine across payers and provision. Really lovely and thoughtful advisory committee. And as you have experts in, oh, here, sorry. Oh, how many domain builds have there been? Jonathan, do you mean like for the new domains? I think we're at 21 gravity domains now.
In total.
In total.
Yeah.
And counting. 2 each cycle now, likely through the 4-year partnership with Registry in adding. So yeah, 21. That's a lot. And so that's 21 across those 4 core use cases: standardized assessment instruments, diagnoses, goals, and interventions. Right. And so these are this meeting is the enhancement cycle, right? So deepening into what we mean and having a terminology for interventions by expanding those HCPC concepts, right? And deepening into the implementation with a program classification. But there's 21 total domains across those 4 core use cases.
Thank you. Feel like I switched classes mid-semester and I finally just got caught up. Thank you so much.
I hear you, friend. I know you've been a part of it. It's a lot, though. I know. I'm glad the last meeting was helpful. You can see why there's all the plate spinning all the time. So very grateful again for this advisory committee. We couldn't be doing what we do without them. I'm going to pour myself some water. Next slide. And so this slide is unique to Gravity, the advisory committee. We don't usually have, an all project advisory committee, but this should look very familiar. Like Gravity convenes subject matter experts for each of the domains of reference. Gravity and our friends at Fullwell have convened, and friends in the advisory committee have convened subject matter experts in each of these 3 concepts, right? So we have subject matter experts in produce prescription, subject matter experts in medically tailored meals, subject matter experts in medically tailored groceries. And across these entities, there's experts in direct provision, experts in payment, experts in nutrition, like we have our RDNs, right? So you have each of these work groups has the complexity of expertise to wrap around what's needed for those concepts as well. Katie, do you want to say anything else on there? This is your brilliance here. So I just want to know a nod to Katie and Kristen.
Too kind. And I will just say there are so many of the people on this list in the room right now. Thank you so much for being here. And it was incredible to get so many applications, like people are really excited about this work. And the other thing besides geographic diversity as well as rural and urban is we also looked at providers who are sort of in the for-profit space and nonprofit space. We understand like all of those dimensions change how you think about these services. And so excited to see that diversity of providers represented.
Very important, yeah, because some of the concepts we're addressing in our work is what is the standard for the standard, right? In that diversity, what is the common line that we're going to draw through all of those different implementations that sets the bar, right? Very exciting work. All right, so you can see an incredible wealth of expertise that I have the honor of meeting with in these every other week subject matter expert meetings. We've been just meeting, we have our 3rd meeting for produce prescription this week. So just kicking off, right? Just starting some of the concepts, some of the high level concepts we'll be discussing today, but more to come on, of course, all of this work. But again, very excited to finally bring it to all of you. Next slide. So just again, what are we leaning into with HCPCs? We have not built in HCPCs before in Gravity. We leverage HCPC concepts extensively to whatever degree we can. There aren't a ton of social risk specific concepts. So you can see HCPCs level 1 concepts, the medical nutrition therapy concepts, which are supported by registered dietitians and nutritionists in our food insecurity value sets. You can see some of the concepts in CPT, HCPCs level 1 and level 2 in our reimbursement for screening, you can see those new HCPCS level 2 concepts, the community health integration and principal illness navigation and social determinants of health risk assessment codes, whew, mouthful, that the partnership and our friend Tim McNeil worked to steward for Medicare concepts. Those are all in our value sets, but leaning into development is new for us. Not new for me. I've done lamely in the past, little bits here and bits, but this is partly why I solicited my friend Tim to help. So HCPCS level, so there's HCPCS, there's 2 different types, even though we sometimes merge them. HCPCS level 1 are also known as CPT, a nod to our amazing friends, the American Medical Association, who are significant supporters of the work that we do at Gravity, both in the technical work stream and terminology. So those are, again, managed by the American Medical Association. HCPCS level 2, the area we're leaning into, really because of that primary Medicaid, Medicare, use case, is the standardized coding system that's used primarily to identify products, supplies, and services. It's managed by the Center for Medicaid and Medicare Services. I can state as an FQHC, I'm a federally qualified healthcare provider in rural Vermont. HCPCS level 2 are the name of the game up there. It's pretty much everything we do to align with HRSA and our quality measurement and reporting and our novel programs and our grants and attesting to the feds about everything we're doing. And so those HCPCS level 2 concepts are going to be significantly implemented in FQHCs and community health centers across the ecosystem. Oh, so the great thing about this, Lucy, is this is one of those instances we might have, it might have taken some time. I'm going to frame this a little bit lightly for us to develop these concepts, but we are leaning into this now because everyone is asking for them. Right, whether it's the White House Hunger Initiative and the drive there to elevate food as medicine, or even the nutrition security framing within the White House framing, which is new, or all of the incoming in lieu of services agreements, CMS, Medicare Advantage programs, like the terminology to support social care services delivered is a very pressing topic, and Gravity was lucky to work with friends in the ecosystem. Well, Gravity's both honored to be a place where we can work on these things, and has been, kind of orienting and like moving the clamshells to ready for this moment for some time. Just a note, as Gravity did that payment and reporting discovery use case, and also Gravity hosted the Social Care Voice Co-Design Initiative last summer. Developing terminology to support reimbursement of services was a key finding from both, right? So not only was it something that we set into our strategic plan for into early 2024, it was elevated by the Social Care Voice Co-Design report, elevated by discovery again in 2024, and in the process with our Coding for Food work. So it's very much like everyone's saying the same thing. Oh yeah, the great thing about this is it's selected, right? So just like IC10CM codes, you use them because you're giving the thing, Lucy. It's a little bit different than like a LOINC code to support like an instrument. Entities want to use CPT and HCPCS level 2 concepts because they equate to cash. They are money in hand to support programs. And so providers and clinical systems, FQHCs want to use them to support their bottom line. CBOs want to use them to support payer partnerships. Right, so this is a unique one where the driver is a very significant driver. It's kind of like why people are leaning in more and more to use ICD-10-CM. So it's driven by use, not by design, right? You don't have to build the code behind your referral pattern. There's no SNOMED code in the background. It's in an invoice, in an e-bill, in like an arrangement that to compensate an entity for a service provided. Katie, I don't know if you have anything smarter to say about that, but that's like, it's a different driver this time. I don't have to wait for NCQA or CMS to build it.
Yeah, and I would just say, the thing I've always loved that you've explained it to me is right, your claim or your e-bill, it moves with a patient. And so as we think about a patient story, it not only tells the patient story, it also moves with all the money, which is what drives lots of healthcare.
Michelle, one of our brilliant SMEs is saying it's administrative data, not always payment. Noted. Yes, not all CPT and HCPCS codes equate to payment. Thank you for that caveat. There are a lot of that don't, correct. And my apologies if I was slippery in my it is a different driver though, regardless, than some of the more obscure terminologies that are behind the scenes. It's applied terminology. All right, next slide. And again, SMEs, this is your space. You can talk. This is not, yeah, this is your forum as well. So one thing that we just want to note is that as we build our HICPIC definition, these service concepts, again, the medically tailored meals, medically tailored groceries, and produce prescription, they really are a series usually of must-have components. They include the product definition and components of the product, including whatever quality standards or quantity standards we want to set. This is partly what we're working on in our subject matter expert groups, like what is the standard we want to reference. They can include timeframes if they're applicable, like how you apply the HICPIC concept. I'm calling this out because it's important to note what we know from our experts and what we know from our subject matter experts so far is that labor, like Katie was talking about that what the partnership has already done, which is a core concept for some HICPICs and a core concept in our food is medicine, medically tailored terms, because of the role of the registered dietitian, may need to be carved out in a separate concept, but it has to be considered in our work, right? So we are deep in the thick of what we mean by medically tailored and the role of nutritionists in that work. We're very, very lucky that so many representatives from the American Academy of Nutrition and Dietetics are part of our work, and figuring out how to represent that is definitely something that we're going to have to address over the course of the next. Oh yeah, Denise. That was your moment. Exactly. So we've been really, really grateful. So if you all remember, the Academy of Nutrition and Dietetics was actually our subject matter expert of reference, along with myself in the food insecurity work. So they've been very involved in this work for a very long time. Very grateful. Next slide. We wanted to go into some important to note as we start this work, and again, our SMEs already saw this bit, there are codes that are extensively utilized because they're all we have right now. These are the three workhorses of the food as medicine world. If you look, we'll talk more about the language scan that we did. I didn't do it, that our amazing friends Katie and Kristen did, about use of these concepts. And also I want to note the Partnership to Align Social Care Billing and Coding Work Group did a very similar analysis of how these concepts are utilized in different settings. This is partly why we share work in this. These three concepts exist. They will not go away. So part of what, yes, Michelle, thank you for your little pearls. She's so brilliant. Thank you so much. These three concepts will not go away. And so part of what we need to, and we have to be very careful, CMS doesn't usually approve any concept that is a duplicate to an existing concept. So we are noting how these concepts will continue to exist as we go forward and ensuring that we're considering how our concepts are different. But if you look across the implementation of these concepts in order to represent the multiple concepts in food as medicine, there's just no set standard in any different rollout or entity, and that's the why of this, right? If you're trying to analyze outcomes across different states with different systems, it's just not been possible. That whole bit is part of the why in the kickoff that's available on the Confluence. Next slide. Michelle, again, thanks for those wonderful concepts. Okay. Where we are starting in our work in coding for food, again, we're right in the thick of it, is the base evidence. Gravity works again with always from some base evidence regarding the domain. We include that in our pre-work. Very grateful for our friends in the ecosystem who did that base evidence. The evidence that drives the why was basically an all US program scan about different operational definitions for each of these different concepts across different implementations, different state programs, different payer programs, different, all kinds of different analyses, because we're using that as both the why for why we are doing this work, but also trying to find the commonalities across all those different implementations. That is also helping us because it's helping us ask critical questions about the service itself, right? So questions about what is the service itself, because if you look at each of those different implementations, there are common themes and differences. And then another question that we're asking in the basis of that scan and based on the subject matter expertise in the room is what elements can be left to state or payer level operational definitions and differences, and what is the base standard, right? Like, we cannot codify likely how much money is included in align with the HCPC concept. We are considering, likely we're not going to standardize, or possibly we might standardize. We're leaning into the method of how it gets delivered. For instance, we're talking about with produce prescription, differences between prepaid cards and actual provision of vegetables, more on that later. But when we think about the HCPC concept, some of it's going to be written into the definition of the HCPC concept by design, but there will be additional capacity for subtleties and differences in operational rollouts in different state programs. So just like we use S5170 now, and you can add a modifier and change it for a specific program, that capacity will still exist. So we're just going to try to figure out what the standard for the standard is. We're also leaning into what's best in a modifier, because what we do in clinical practice with CPT and HCPC concepts is often use modifiers to add additional information. Those modifiers are pretty much extensively used right now just to help those 3 SAD workhorses, long-standing workhorses, represent the complexity of what's out there. But those modifiers will be able to be used for different purposes going forward. And so what our job is also to consider what's part of the concept, like what is part of the definition of the service, and what is best in a modifier to represent additional value. I know this all sounds like Greek likely, but we're talking about the different cost in delivering something to a deeply rural area via the mail or UPS, right? Like, that's a cost that's different than dropping it down to your neighbor 4 blocks away, right? We also are talking about cultural modifications, because a core element of, autonomy and patient-centeredness and even food security is culturally modified services, right? So is that best in a modifier, or is it part of the base component? SNAP does not fit in here. That is a very good question, Lucy. So SNAP is a federally supported existing resource. It does have some guidelines regarding what you can and cannot use those funds for. There are many, if you look in our Gravity, the program classification work that's just about to be on the screen details how there are actually many aligned concepts within existing federal programs, but these HCPC codes fundamentally by design represent something different, right? And so they are, like, if you think about, like, there is, older Americans farmers market programs. There are special, WIC farmers market, WIC farmers market programs, right? Katie's nodding because she's a food as medicine specialist, right? So that is not what we're talking about here. Those programs should be optimized always for any entity who can qualify for them. That's a core principle. We were just talking about that in our Infinity meeting or our Affinity meeting a few minutes ago, but that's different. So these are differently different programs to be funded through different methods. Whew. Okay, I think we're doing a good job. All right, next slide. All right, so we do have some of our produce prescription SMEs on here. So the hot off the press, my apologies. I literally tried to synthesize information from the meeting we had yesterday when I was in clinic. But I do want to highlight as soon as I can some of the themes we're getting from the specific meetings. These are the things we're hashing out. Again, this is not a definite, here's where we're landing, but I want you all as a community to understand what we're talking about, so you can come along with us, right? So we are a consensus community, so you coming along with us is part of the design. So when we think about the language, the literature scan regarding programs, or we think about the subject matter experts in the room, we know we are hearing about different methods of providing the service of produce prescriptions to an entity. We are hearing about prepaid cards versus direct provision of vegetables. We are leaning into the idea that we want to be able to represent the breadth of those concepts, whether it's in one concept or 2 concepts to be determined. But that the diversity of that is really important when it comes to how we do what we do, in the produce prescription world. We are leaning into concepts and quantity. Again, SMEs, this is your world. You can feel free to interrupt me. And these are like say your wisdom in your own words. We are leaning into how to represent concepts in quantity to allow for standard measurement, not to overly medicalize, mind you, but a consistent understanding of the amount of a thing someone got is very important when you think about outcomes evaluation and healthcare, right? If you're not giving for a food insecurity sole concept, but you're trying to like literally treat diabetes or hypertension with a produce prescription, it's important from an outcomes perspective to understand that a person got a certain set amount of thing, right? And so we've been talking about how to operationalize that within produce prescriptions, but not over constrain it beyond what we already do in healthcare and find that kind of middle ground, right? We even talked about like dosing mechanisms yesterday on the call. And Adam, if you have anything, I mean, I see all you sneeze there. If I'm saying anything incorrectly, holler, you're all there. We're also leaning into how to represent concepts and eligibility. So the word prescription is in this concept by design, right? So we are leaning into what that initiating action is, who are the types of providers that initiate that service, and different types of medical necessity, right? So is this included in the service by definition? Is it only a produce prescription if this has been met? Or is that subtlety that can be represented in operation, like a general term that can be constrained with a modifier for medical necessity in a different area, like in a different setting? Is eligibility a typical consideration in co-development? I believe not. Originating action is actually a very common concept in some HCPC concepts, like how it starts and what has to happen as part of it, especially in social care and clinical care partnerships, right? So medical necessity, not so much, only these conditions, but how it's initiated, yes. And that's why it's a to be determined. Michelle, did I answer your question? Okay. Those CHI concepts that were just released are a really good example of that. They have to start with and be authorized by a provider. You have to document your problem list concept in the problem list. You have to share information with the clinical entity. They have to support that CHI term, right? So all of that was written into the community health integration labor code by design, right? A food bank can be delivering the CHI, but the provider, that relationship and the initiating action is part of the concept by definition. Okay, I hope that makes sense. And any other comments on produce prescription? One other thing I want to note, and we didn't say this here, but we understand that creating the standard is not going to be the standard necessarily for all of the entities in the room who are subject matter experts. We're having really wonderful conversations about what that means, right? What is the standard we're comfortable resting on to move the dial forward, right? Knowing that S5170 and those other concepts still remain. Okay, next slide. It's already 4:46. We're doing pretty good though. Half time, 45 minutes. That's what I said we'd do. Okay. Okay. Or okay. Again, I've been talking for a long time. So we wanted to just highlight something that's pretty important. For two of the concepts, we have medically tailored meals and medically tailored groceries, right? These are concepts that are extensively utilized because of the brilliance of the registered dietitian nutritionist and how they help drive specific like produce or meal plans that support the uniqueness of that person or the uniqueness of the person's conditions, right? This is where the evidence base starts to rise, right? Like you see lots of studies analyzing medically tailored meals and medically tailored groceries and clinical outcomes, right? And this is partly where you start to uncouple food insecurity only from the driving concept, right? And I see Rosie nodding. So the moment we use the term medically tailored, we're thinking about that labor concept, which is usually different than the service provided, the thing. So the meal and the labor are usually thought of different. We are really leaning into what, how much of that tailoring can be the standard. Like what is the, what is the breadth of how this is operationalized across the ecosystem? Is it tailored by diagnosis or tailored to the person, right? And because we have to, we are having lots of conversations with our friends who are registered dietitian and nutritionists, of which some of our SMEs are on the call, right? Leaning heavily into our friends at the American Academy of Nutrition and Dietetics, because again, we want to make sure that if the medically tailored evidentiary base of this concept rests on their labor, that we are understanding how to support that labor in whatever HCPCS code that we develop. There are limitations to how, and again, we could have a whole seminar on the hidden labor of RDNs across the ecosystem and how current payment models do not adequately compensate RDNs. As a nurse, I feel like that's I'm just like, the more I learn, I'm like, hi, I see you out there, friends in the critical but non-billable services. So we're leaning into how to operationalize this, because there are some current limitations on how registered dietitian nutritionists are able to bill for their amazing expertise at present. But we just need to know that when it comes to medically tailored in each of our two concepts, that labor is happening, right? It is that labor that differentiates the medically tailored meal and the medically tailored grocery from something else. Does anybody who is an RDN on the call want to say anything else? I hope I did you justice. I'm channeling Carly. Hi, Michelle. I wondered. I wasn't want to calling you up for speaking. Yeah, I know. I'm like,
Yeah.
anyone?
Thanks. You know what? I'm so glad you called this out, because absolutely understand that we want to look at the meals separately, and there is always the labor component. And, like, for example, for professional services, that something's factored in. But what I think is most important to call out is because of the gaps in nutrition care and coverage for nutrition care for many populations. I will say an example is Medicaid, where the federal government does not require that any states provide any benefits for medical nutrition therapy, nutrition care. It's patchwork across the country. We have coverage in Medicare for a couple of diagnoses. Support the MNT Act, please. And so you have this patchwork of coverage that, whether it's commercial, Medicaid, Medicare. And so for some places, you have this mechanism through the MNT CPT codes to provide the professional services that are often accompanying that decision process for determining the therapeutic diet for the individual. That may not be needed in all situations, but I think that is part of the struggle. And so there are many places where that mechanism may not exist, but as you were just highlighting, the labor and professional services connected to the medically tailored meal, there isn't that payment mechanism in some states. So I think that's part of the urge to include that. Does that make sense?
It does make sense, Michelle. I mean, this is like partly what I said before, is even if gravity can't, and this is again, not a new thing for gravity. We are raising many policy considerations in our incarceration status work and language access work that are outside of our scope to directly solve, but we do attest to the problem in a public consensus way, right? So just noting that that the complexity of addressing how MNT is compensated is not something we can necessarily fix, but we're going to elevate it and speak to it and center A&Ds and how you're critical for this medically tailored meal concept and others and medically tailored groceries. Go team. Michelle, I hope that was good. Okay. All right. Awesome. Oh yeah, and then our friend Denise. Hi. Longtime gravity friend. This is your moment. Oh, buddy, that's so sad. Okay. I know. It's like this is why
I know it's my moment. I've been waiting, since 2015. I can finally talk, but I'm going to defer to Michelle.
I know, I love it. And we do have lots of friends from A&D helping as well. I want you to hear, Michelle and others, that if we're leaning into medically tailored, we understand that it's your expertise that drives those outcomes.
Yeah,
Supporting this program. And we're gonna try to figure out how we can go forward. Okay.
We're following. Good job.
Thanks, buddy. All right. Okay. So that's just some quick picks. Next slide. Some more to come. We're going to switch to classification soon. This is very small text. Michelle, do you still have another thought?
I'm sorry. No, not at all.
Your cute little hand was still up.
Oh, I'm sorry.
No, I know. I'm really bad at that too. I just wanted to make sure. Okay. So the work groups are continuing to meet. Look for draft concept definitions and policy considerations at the next meeting. Again, those policy considerations, just because if we can't solve some things, we're still going to use our consensus space to elevate those concepts. The specific definitions for the services, we should be able to have something in process for you in the next meeting. So super excited. That was a 45-minute deep dive into catching all of you up in Coding for Food. Bring your people to the next call in 2 weeks. Feel free to send us questions. Katie, I hope I did. I don't know if we put all the possible resources for Coding for Food in the chat. Anything else to say before we switch topics?
I think that was a lot of information. More will come.
That sounds great. All right. Okay. Sounds good. Okay. Whew. Now, switching topics. Next slide. Thank you so much. So excited. Coding for Food is great. Any other questions from anybody else? Okay. Again, I don't claim to have a favorite domain, but this former food insecurity SME is really happy to be home with all of my food bank friends in my so it's really nice. There was a National Produce Prescription Collaborative Summit in DC last week, and it was literally, Brent Bling called it like a wedding. It was like a wedding. It was like meeting all in person all these friends I haven't seen for a very long time. So excited for this work. Okay, now pivot. Now we're talking again. So those of you who are coding for food SMEs, feel free to stay on the call. If you want to learn about the open program classification for social care and organization, you're welcome to. But just want to note we are switching topics. And thank you so much. And again, this will be the cadence going forward. So coding for food people, you will always be first so that we can flip into program classification later. All right, program enhancements. Next slide. All right. This is an outdated slide. So these are the 3 topics in program enhancement we're working on: program term analysis, program classification, program documentation. I said this last time, I'm going to say it again. I did not know what an excellent opportunity for analysis of our program terms the program classification would be. Looking at Gravity programs from a different lens has been incredibly informative. You will see this across our program classification work. We are going to be bringing to this meeting Gravity defined programs for consensus, part of the consensus vote for November 21st that are arising out of this enhancements work. So lots to come on that. And of course, the core work. And we have one of our SMEs on the call regarding that is the program classification. And sorry if I'm missing somebody else. And again, it was this idea to leverage all these amazing friends in the ecosystem to develop a shared classification to support exchange of social care program information and to support navigation and connection to services. Next slide. All right. I think we're doing good. I just need to keep on drinking water. Next slide. All right, this is the Gravity terminology curation process. I could have put this in front of Coding for Food because it's very similar. So we convene lots of pre-work always. The Coding for Food pre-work was a good 2 years in the making. Once we kick off our public calls, we use this space and our subject matter experts to identify missing concepts. They then go through a very formal end-to-end review and a formal vote. And then Gravity works to build the concepts. And so for Coding for Food, we're submitting to MIRIS for HCPC concepts. For program classification, we are going to be submitting to any standard code system for program type gaps, and then publishing the classification. Next slide. All right, and then I think I might have a delay on my side, unless it's, oh, there we go. So the subject matter experts, we are so honored to have this amazing group of entities supporting us in our work. It is really an all hands on deck work. I want to note deep appreciation from our friends from 2-in-1 LA, Find Help, Epic, Unite Us, and 2-in-1 San Diego, who are coming together to do this work. Again, each of these entities, I mean, 2-in-1 San Diego is a polymath. Elena is a special beast. She always is special. But each of these entities, 211 has 211 HSAS, Find Help, Epic, and Unitas also have all of their own classifications. So working together to create a common classification is work that they're doing for the greater good. So incredibly grateful. And grateful for our friend, Alina Kalinowski, longtime Gravity friend, who's worked in the intersection of all these things. So I kind of like, she's like the babble fish of each of the different classifications. You know it, Alina. Next slide. So the goal is this open USCD Island classification of social care program categories and programs and to enable navigation and connection to services. Both by health and social care providers and by people who are self-navigating. So if I'm trying to find help, how do I find it, right? And so this is deeply embedded in our work. And the cool thing is about with our SMEs is they are experts at curating their own open classifications over the course of decades and sometimes many decades. So synthesizing that work is the name of the game. The cool thing about once we have these concepts, it won't, the use of these terms won't be just the classification itself. So we'll be able to use those program type terms to enable mapping to alternate classifications to be used in outcomes evaluation. The directories, the use is pretty significant, right? So even though our driving organization is connection to services, navigation to and connection to services, the ensuing concepts will be able to have multiple applications. Next slide. It's funny, I sound very terminology today. I think probably because I'm tired. Sometimes I'm like, I was once a farmer. I didn't used to use these terms. But the structure of the classification is going to be published in open space. We don't know where yet. We have ideas, but there's many ideas. And so that's more on that to come. Next slide. And we're going to get, again, our subject matter experts are the SMEs of reference, developing the classification, presenting it to the community. Community reviews the classification and we revise, and then we aim toward that common November 21st vote. Next slide. Again, it's built for navigation and connection to services. So it's really important that if you're submitting requests for concepts and altering, that they are built with that in mind. Again, like it has to be a structural analysis of what of the function of the organization for navigation and connection. And it's built in increasing levels of granularity. We'll get more into that in a second. Next slide. So these are our domains we're working through. Again, we did some revisiting of housing this week based on observations, and we'll go into that. I think we actually achieved a couple more of these that I should have turned bold, but I did not. So you'll see the method of how we approach the high level groupings and the secondary level groupings very shortly. Next slide. And again, it's the part of what we're using, the method of what we're using is understanding how social risks are subdivided into different dimensions. And the reason why that's important is these dimensions usually align to different programs. How I help a person stabilize worry or stabilize a lack of stability is different than how I help them if they don't have it, right? How I improve the quality and safety of a domain is different than, they have to have it to improve the quality and safety, right? So these core dimensions are common across almost every single standardized instrument we have for our domains. You can see them across transportation insecurity, utility insecurity, housing insecurity, food insecurity, right? And then we're seeing this structure apply to our classification as well. Neat things. There's probably a paper in there, Alina and Hamali, that we should write at some point in time. Next slide. All right, so you can see this play out, right? So you have the primary need. I need help with food. I need help with housing. I need help with transportation. And then generally, you have these different subtypes, like help paying for it, help acquiring it, or help with maintenance and quality. Next slide. There are some domains that break this. Housing has broken everything so far because housing is so. And again, so when we see, you're going to see this very carefully. We talked about this last meeting. The neat thing that we're seeing as well is if you think about your core primary domain and then these program type groupers, Gravity is next with this kind of level of like general national programs. And then because we are like members and users and implementers of social care program taxonomies such as 211 HSAS, we can see that next level of granularity coming in after gravity programs that are like basically adapting gravity programs for specific populations or specific conditions or specific instances. And again, those specific instances are really significant, really important when we think about eligibility, which is something we talk about a fair bit in their classification. Next slide. We've talked about this a fair bit in gravity too, like transportation, access, accessibility. Like you can't send a van to somebody unless you understand if they need an accessible van, right? So these kinds of components are really critical when we think about subtypes. So gravity has a non-emergency medical transportation code, NEMT, but it doesn't subdivide it into the different features of that program that are meeting the needs of that specific person. And so this is where like a 211 HSAS comes in, right? And again, this is that laid out again. So you see the facet of the primary need, the program type grouper that we're working on, where gravity fits in, which is the subtype level, the gravity concepts, and then very, very grateful for the wisdom of social care taxonomies, such as 211 HSAS that take it even further, right? Next slide. All right, oh, I see comments. Am I missing something? Oh no, these are I just missed these. Okay, and then housing. Whew. We had another huddle on housing this morning. It's complicated, so we're going to go into that very shortly because we'll go into that in slides. The housing is complicated for all kinds of reasons, and we're leaning deep into that into our subject matter expert meetings and hosting another special session. Housing's required not just one special session, but 2 special sessions with our SMEs just to try to get the marrying of the different classifications correct. Next slide. And I love that our Coding for Food SMEs are staying on for this. Adam, I see you leaning in. I love this. It's just so fun. I'm sure from implementation perspective, this is fun for you, right? But so this is the cool thing that we didn't anticipate. I did not anticipate that Gravity would understand gaps in Gravity programs as significantly as we are through this work. So many different types of programs that we are missing, different roles. And you'll see this in the master classification. Everything that we're missing and Gravity is leaning into is bold and in purple. And Gravity will work with, we have every single program we submit to SNOMED CT has to have a referenceable national definition. So we're going to work on refining those concepts, presenting them back to you, as I mentioned, and then including them in our consensus vote on November 21st. Again, lots of details on those gaps in the classification itself. All right, next slide. All right, I think in the next slide, I think are we go backwards or we go forward? Oh yeah, we went the wrong way. Next slide. Or maybe I did it. Maybe I went the wrong way. Okay, so we're going to go to the draft classification now. Same thing we did last time. I actually, because there's some updates, I want to take you through the master updates. So we're going to go to the draft classification after the last slide, Hamali. So I'm going to show the master changes from the last list and before I go. So there's no way to represent the complexity of the classification. Oh, sorry. If we can just share slides one more time. Okay. I messed up. Share slides one more time. And then, oh, bye, Adam. Thanks. Sorry. I'm going to share some master updates and then we're going to go to the classification because I want to talk about those master list updates before I go. Hamali, does that make sense?
Yes.
Yeah. So next slide. Note that the legend there. So when you go to the master, you're going to see anything in italics is something that is incoming and Gravity has been working on already, like from utility and security. Again, what's in purple is a Gravity gap that we're leaning into, and anything green is something that we're still, it's like a sticky wicket with the SMEs that we're working through. I love it. I know. Bye, Lucy. Sorry. I love all the different food folks on the call. Oh yeah, so I can imagine it including Denise this question I can imagine including classes, like in our nutrition, there's a nutrition, like in the quality component. Like lactation services, I imagine can be within the food component possibly. Thanks for calling that out, and we'll bring it to the SMEs, right? Because how we would intervene, you know, and just to call out as well, I specialize in pediatrics. We talk about infant formula, but there's also breast milk donation. We do not have that represented as well. I'm just going to call out that gap as well. So Denise, thank you for centering on that. If we talk about supporting lactation services, I imagine it's a referral to lactation consulting and maybe filling a gap by talking not just about infant formula. Does that make sense? I'm hoping it does. All right. But those are, so Himali, just note to self, those are two things we don't have either in Gravity programs or on the master yet. So we'll have to add that to our list of things. So here are some differences you're going to see on the master lists. These are, most of the master list updates are just mistakes I made on Friday when I tried to make the master ready for publication. So very few of the changes on the master are actually updates. The ones in housing are. So if you notice the classification, the master classification we published is not the same thing as the one I showed on the call. And my apologies if I didn't thank the Coding for Food SMEs enough before you all left. My brain's a little addled today, so I've been talking for a very long time. So thanks, Coding for Food SMEs, if you're still on here. And I appreciate your work. So one of the things that I did not do, if you look at how we're organizing the classification, we have that high level need, the program super type, the what about the X I need help with. And then we have those groupers we're working on, which is the main effort of the classification. And then Gravity comes in. Our friend Rob McClure on the call last week correctly identified that some Gravity programs are also arranged in program types and program subtypes. I didn't apply that everywhere. So I wanted to note that in the master version we published, diapers were a sister to infant supplies, but they're really a child, right? So diapers are a type of infant supply, right? I didn't correctly put that into our concept. So that's an error just in my presentation of the work that we fixed in the next version of the master. The master will not be updated until Monday because Sarah Bahal's out, and we just want to reconvene and make sure we aligned on master updates. Next slide. And then now we're going to lean into housing. Some of these updates are directly from our subject matter expert gathering. Housing is the most complex domain, period. It's been complex from the beginning. It's maintaining its complexity. Our program classification is organized by purpose, right? So shelter, homelessness prevention, permanent housing, and many programs span purposes. So that's been tricky, right? And so we're trying to figure out how you have a purpose-driven classification, and the complexity of cross-purpose programs is hard. We are really leaning deep into how to organize this. Again, we did some significant revisions this morning, trying to simplify our classification type groupers, really to support that multiple programs, like multiple HUD programs fit into multiple types. We did do some updates on our housing quality findings. We're going to present, and then we're going to go to the master very shortly. And we did have some updates on programs to support unhoused individuals that are not directly housing. So we're going to go to those in the next slides, and then we'll go to classification. Next slide. So when we noticed, if you did download the master last week or 2 weeks ago or whenever that was, it's all a blur. We did not have super type program classification types for these core programs that are across national instances, such as mold remediation or residential abatement or asthma trigger remediation. So we created program classification type groupers for those. You'll see those on the master list on Monday. And again, these are just to develop, like this is the bidirectional analysis, right? So we had Gravity programs so that I have a good grouper. So we had to figure out what that grouper would be. We did call out asthma remediation specifically because it's such a specific thing, and it's unique because it goes from both assessment and treatment, right? There's a very centralized HUD driven curricula regarding how to enter a home and remediate, assess asthma triggers, remediate asthma triggers, wraparound services, et cetera. So we wanted to call that out specifically. Of note, asthma remediation is a concept that Gravity has been asked to consider developing HCPCS codes to support, right? So in our work that we were just talking about regarding coding for food, you know, leaning into HCPCS concepts to support provided services, we have been pinged on enhancements to both asthma and additional concept with housing already for next cycles of enhancements, and are continuing to talk to entities that want to help us with that. Next slide. Okay, yeah, and then we did want to note that we had medical respite, which is a type of pre-admission and post-procedural specific clinical housing for unhoused individuals in our shelter category, but it's really a clinically driven problem, right? It's like you get medical respite or recuperative care for prior to your knee replacement, or discharge from your CHF exacerbation, your heart failure exacerbation, and that's to support, you know, stability prior to the procedure and to support the facilities post admission or procedure, really to prevent readmissions and support the person in healing. So because they're so clinical, we realize they're actually not about the shelter, they're about the clinical problems. So we pulled them out of seeking shelter, and we're going to figure out where they go. And then we also have all the host of, you know, different programs that meet individuals who are unhoused, but are not specifically about shelter, street outreach, mobile clinics, healthcare for the homeless programs, and we're thinking about where they go as well. We just recognize that they were not correctly in the seeking shelter because they do not offer shelter. They're different. So more to come on that. I hope that wasn't too many words. And then now I just want to walk through the classification briefly and then let you all have your Thursday. And have some tea because my throat is a little gravelly. All right, so we are going to share the classification now. It's new for those of you. This is not what I presented before, which is why I want you all to be with me, friends. Friends. I tried to minimize my tabs. This is a classification that shows the brilliance of my amazing friends in the terminology workstream, Hamali Sejwal, who's on the call, Sarah Bahal, and Monique Van Berkum. So you can see that there's concept IDs starting to happen in column A. That's a similarity you can see from across our other masters. That helps us with tracking. You can see, okay, oh, so we're not talking about HCPCS concepts for the homelessness considerations yet, so I don't know how the modifier question relates, Denise. When it comes to building any HCPCS concept for housing, which is future work, not this work, there likely will be different modifiers than we were talking about with food. Did I answer your question correctly? Okay, I'm sorry. And I might be blurring because, again, I've been sitting here talking since 2:30 in the afternoon Eastern Standard Time. So if I'm starting to blur concepts, my apologies are not being clear. So the organization of the master has changed a little bit. So if you were on the call again, hearkening again to our friend Rob McClure, he was talking about how it's really helpful to have a line-by-line classification. We did that because what I realized, if I sent out the classification as I had it, people who weren't in the meeting wouldn't be able to follow along. Our materials need to be accessible. So we did a line-by-line classification here, each with its own identifier. You can see we have the program super type, which is the what about food do I need help with? The program classification type, which are the concepts we're working on defining with our synthesis of all the classifications. Gravity terms are all in column E. And again, anything we're leaning into that's missing is in purple. And then anything that's a child of an existing gravity program is in column F. Right. And so you can see like the FDIPA program is a child of a food pantry program, both in our gravity work and in the classification. So in housing is where it gets sticky. There's a lot of work happening here. There will be very little housing updates, except for the ones that I mentioned before when we upload the master on Monday, because we have a bunch of work sessions to try to figure out housing organization. But we're doing pretty great work. And the great thing is, you know, as we lean into housing, at least to support the for, domains of reference across, federal programs and regulations, we should have a pretty good set of a classification done very shortly. Mostly I just wanted to walk you through the organization of the classification before we called the call, because everything else is a work in progress. Any questions on the classification organization? We all good? Any questions from my friend Tom? You're such a navigator. Any questions from Tom? Sorry to call you out. You're such a great synthesizer.
No questions today, Sarah. Thanks.
Okay, sorry to call you out.
No, actually, I need to follow up with you about another issue, but I'll do that offline. Thanks.
Okay, sounds great. Okay, great. Okay, so I'm going to stop sharing. So a version, again, we're going to go back to the slides. Again, thanks for our subject matter experts on the call. We can just go to the homework. Next slide. Okay, next slide. So on Monday, so always catch up with any materials on the Confluence page, right? So everything regarding coding for food, you can find on the Coding for Food Confluence page underneath Food Insecurity. The program classification master will be posted on Monday. It's under the cross-domain enhancements work there. Again, it's not going to be available until Monday, not Friday. The latest version of the, oh yes, thank you, Molly, she's reiterating. If you are a classification friend who wants to keep on working in the classification, this is where that meeting, so Coding for Food and Classification, coming back to you in 2 weeks' time. Next week, for those of you who are being part of that meeting at 4 o'clock Eastern Standard Time next week, it's language access and incarceration status. Again, thank you so much, friends. And I hope this meeting was helpful. Any final questions before we go? Katie, you stayed down for the whole thing.
All about learning the process. Got to see it in action.
I know. Now you know why I've had to form other lobes of my brain just to hold all of the different knowledge making. It's a lot. Any other friends? Thank you so much. Again, please mobilize anybody who's using classifications, any of your community-based organizations who care about this, anyone delivering anything regarding medically tailored meals, medically tailored groceries, or produce prescriptions. This is their moment. We want you here. And those of you who are involved in the normal new domain terminology development, we will see you next week. And now, tea.
Thank you. Thank you, Sarah.
Bye, dear Rosie.
Bye-bye.